Thank you for joining us. I'm Amanda McGill-Johnson, the Executive Director of Nebraska Cures. Nebraska Cures' mission is to promote, support, and advocate for health science research and education for the betterment of our health and for our economy. Today, we're hosting this webinar on a very important topic, taking a deep dive into the brain science of addiction. For those who have someone suffering from the disease in their life, a loved one, perhaps someone they're working with, it can be difficult to understand what's going on in their brains. So we have with us today Dr. Kenneth Zoucha, Director of Addiction Medicine for the Department of Psychiatry at the University of Nebraska Medical Center. For those of you who are listening in live, please feel free to pop whatever questions you may have into the chat, and we'll get to those as appropriate. And we'll also be sharing a recording of this presentation in the next day or so you can access it in the future, so you don't have to scribble and maybe write down everything he says. Dr. Zoucha has an extensive experience that includes his 20-year career as a general pediatrician in Nebraska, and now specializes in the treatment of substance use disorders in adolescents. He served as medical director for several adolescent secure care placement facilities throughout the state, treating youth with a broad array of experiences, background, and trauma. He continues to treat youth in the juvenile and adult justice space through his work with juvenile probation and at the Douglas County Youth Center. Thank you for joining us, Dr. Zoucha.
It's a pleasure to be here. Thanks for having me. Just really great to have everybody on today and to spend some time today. If it's okay, I'm going to go ahead and share my screen.
Please do.
So that we can get this going. So I'm hoping that you're able to see my screen.
Yes.
And I'm going to switch this here real quick because I think I'm going to go ahead and do this, change this over just real fast. I had the wrong screen up, so apologies for that. All right, so thanks everybody again for letting me be on today. So again, my name is Ken Zoucha. I'm a pediatrician.
Dr. Zoucha, we can see your next slide in this format. I don't know if that's intentional or not.
I'll switch that around. It was the screen that I had before, so I'll go back to where I was before.
There we go.
So now you can probably see.
There we go.
Got it. Thank you. I appreciate that. Thanks for helping. Technology is awesome when it works. So, again, a pediatrician and addiction medicine physician, and also a person in recovery from substance use disorders. And so this topic is near and dear to my heart. I had several family members that have had substance use disorders and have passed away as a result of those substance use disorders. So improving our care of folks who have substance use disorders and working on prevention is such an important kind of topic for me. I hope with talking about the neurobiology and kind of looking at things that we are going to get you to the point where you see substance use disorder as a non-choice prior to treatment or prior to understanding of the disease process, which is why we have this term, what's your substance of no choice? A lot of times in recovery, you will hear the saying, what's your drug of choice? What's your drug of choice? What's your drug of choice? The thing that got you into treatment or got you into trouble. So we're going to try to flip that just a little bit and see if we can kind of think about that in a little bit different way. Really grateful to be at the Med Center to be able to do some of this stuff. Here's a few objectives that we're going to kind of look at today and kind of see how we can accomplish a few of these things. The first thing I wanted to do was just start with a couple of stories of patients that I've treated in my clinic. So one is an adult and one is a youth. So my first patient that I want to talk about is Mary. Mary, I started seeing as an adult. She, her history, she grew up in a small town in Nebraska, had a great kind of high school career, did really well through that. Family life was really good. Like a lot of folks, she went on to college, and during college started doing some alcohol drinking during that time. However, her drinking was different than her friends. When her friends were ready to stop and go home, she was ready to keep moving. And when they were saying, you know what, we need to stay home and study tonight, she was saying, come on, let's go out and drink. And so she knew kind of her drinking now, in retrospect, was a little bit different. She became pregnant in her sophomore year of college and really strived to be an excellent mother. She stopped drinking during her pregnancy as soon as she found out, and was a single mom and tried to stay in college during that time. However, she found those struggles to be really difficult, being a single mom and going to school and working at the same time. And so she returned to alcohol use soon after her baby was born. And it was within just a short period of time that she was really drinking all through the day. A lot of my pictures come from a site called Pixabay. So I just want to say that. She started having morning hangovers as a result of her drinking, and actually eventually started drinking in the morning to resolve her hangovers. She had a job, and her employer knew that she needed this job. So they kind of helped her, gave her some breaks in all that, but eventually ended up losing her job. And subsequently, her child had to go live with the child's father as a result of her alcohol use. The next one I want to talk about is Willa. So Willa's 18 years of age. Her presentation to me was that she wanted to stop using drugs and she was really anxious. Her history was that she started using alcohol and cannabis early on, as well as nicotine in her teens. At the time she presented, she had been using opioids and cocaine as well, and had stopped a couple of days prior to seeing me, saying that everything hurt. She had diarrhea and vomiting. You can see her history on there. The opioids started with her parents, who her father had opioids for a back injury. She had heard about those from her friends, and she decided to start tapping into his supply, which is kind of where things started. When I saw her, she had just been unsuccessfully discharged from a treatment center. She had gotten caught with some capsules of kratom. We're going to talk about that in a little bit. Because she was just so uncomfortable, she couldn't make that through. Here's her first kind of opioid use. She just really liked it. Within a short period of time, a couple of years, she was using a large amount of opioids, and eventually had moved on to heroin, using that intravenously. She attempted treatment a couple of times. All of them were abstinence-based, and not allowed any medications for her. In treatment, she felt awful, couldn't focus, constantly thinking about using opioids, and would relapse within a couple of days after leaving treatment. In fact, her last time she actually had lapsed before she left treatment. Here's my kratom sign outside of a place here in Omaha. So the reflection exercises is what do all these have in common? And it's really, substance use that started in the teenage years. The second is ongoing use despite negative consequences. And the last one is just compulsive use despite wanting to stop, despite wanting to do something different and having ongoing compulsive use, suggesting that maybe it's easier to stop after easier to not start than it is to stop. And oftentimes when I'm doing talks for our medical students or residents or other folks, and I ask folks to raise their hands about how many of you do you have a friend, a family member, yourself that has experience with a substance use disorder, and invariably it's 8 out of 10 people that raise their hands and say, that's me, I have that. The first thing I want to talk about real quick is stigma. And we hear a lot about stigma. It's thrown about a bunch, but asking folks kind of what's your definition sometimes can be really difficult. So I wanted to talk about that a little bit today, so we have a little bit better understanding of that. So stigma is defined as this mark of disgrace or reproach, and it's an attribute or a characteristic that somebody has that puts them into a group and makes them be less valued by society or by other members of society. This burden is based on a couple of things. And so the first one is the fault. Did you cause your disease to happen? And the second is the ability to stop. Can you stop using? I remember a letter that I read on a website that is based on helping parents who have kids with substance use disorders. It was a mom who wrote a letter in about herself. Her son had opioid use disorder, 19 years of age, and then her best friend down the street who had a son the same age who had cancer. And she was grieving for her friend because of her son's diagnosis, and in no way said anything negative surrounding that. However, she talked about just how many people were going over to see her friend and helping with their yard work and bringing over hot dishes and mailboxes full of cards, and nobody was coming to see her. And arguably, her son had a disease that was maybe more deadly than her friend's son did, depending on the type of cancer people have. And that, I think, is a really stark example of the difference between a condition that we stigmatize and a condition that we don't stigmatize. With that stigma comes stereotyping, and the stereotyping leads to individuals, being thought of again as less than, or as weak, or stupid, or foolish, or irresponsible. And because of that, there's discrimination. There can be housing things that can be difficult against people, jobs, other types of opportunities that folks have that don't have substance use disorders, treated unjustly a lot of times within the medical community, and again, perceived less valued by others. There's 3 different types of stigma, which I think is just pretty interesting. I didn't my research. So the first is stealth stigma, and that's that spot where the person who has the thing that's stigmatized is stigmatizing themselves. And I will tell you, as a person in recovery, that nobody can put us down as well as we can. And nobody thinks as badly of us as we do, especially before we start to understand the disease process and what's happening. Early on in my life, I had uncles and grandfathers that had alcohol use disorders, and my parents did not. And I heard them talk pretty negatively about my uncles and my grandfathers. And I carried that with me for a long time, about being that weak, stupid, foolish, and irresponsible person. And so when I started having those symptoms, it was a pretty difficult time. And I think a lot of folks feel that way. The second one is social stigma. And that's when you have a group of people who see another group of people as being less valued. And so that is an example is when we have a group of people who are saying people who use IV drugs are bad people, and we don't want them in our neighborhood. People who use IV drugs are foolish and stupid. And so that's an example of kind of social stigma. There are structural stigmas as well. And some of those things are institutional or policies or procedures that are put into place that give less advantages to people who have the stigmatized process. So that can mean housing or jobs. One of the things that happened in the medical profession for a while was when we were applying for medical licenses or applying for different things like privileges at a hospital, is that you had to talk about any past history of a substance use disorder, and even if it was 20 years ago, and it was a difficulty in obtaining those things compared to somebody who wasn't. So what happens then as a result of stigma is you alienate. You get lonelier and lonelier and become less connected with people as a result of that stigma. People looking down on you, people thinking badly of you, people thinking that you're not good enough. And so because of that alienation, your problems get worse, both mental and physical. And then people don't feel like they're valued enough to complete their treatment or to talk to their physician about what's happening. I will tell you, there's many times that I should have talked with my physician about what was happening in my life, and I was just afraid to, because I didn't want to have my physician think less of me, or judge me, or look down on me, or kick me out of that practice. And people have that real fear of that surrounding that. So what happens then is, to continue the disease process, your behaviors get more risky as time goes on. Healthcare providers have some pretty this is getting a ton better, don't get me wrong. So this is studies from a while ago, 2011. But when we looked at physicians asked about their attitudes surrounding patients who had substance use disorders, they saw them as people who overuse the system and the resources. They weren't vested in their own health. Physicians would give them a treatment plan or prescribe a medication, and then see them 3 weeks later still active in the disease process. And that they abuse the system through drug seeking and diversion and manipulation. And they don't follow recommended care. So those attitudes are real. They still exist, but they're getting better. Language is a gigantic part of this, and we really want to talk about language and really think hard about this when we're talking about this. One of the main words that we're trying to get out of the lexicon is the word abuse. So oftentimes you'll see substance abuse, drug abuse, alcohol abuse. And there's a lot of studies looking at that word and the attitudes that brings to people when they hear that. And it equates then people with the words child abuse or spouse abuse or animal abuse. And when you hear that substance abuse along with those terms, you think of that person as being a bad person who just, again, is stupid, selfish, foolish, and irresponsible. There was a study done where we had healthcare professionals read a story about a patient who had substance use disorder. And in one, the story is exactly the same, but in one, they said the word abuse. They called the person an addict. They said that they were abusing their substances. The other one, they called it that person a person with substance use disorder and talked about misusing substances. And when they asked about attitudes after reading the vignettes, the folks that were reading the one about abuse thought that that person needed punishment rather than treatment, were much less likely to say, I can treat that patient in my practice. And really thought less of them, thought, they're responsible for their disease. They should be able to take care of this on their own. This isn't my responsibility. It's the same group of people otherwise looking at that. So that one word had changed. This is my slide from a friend on the East Coast. And one of the words we think about a lot of times is, are you clean? Asking somebody, are you clean? Meaning, are you right now abstinent from your use of substances? The opposite of clean is dirty, and so we don't call somebody who has a 300 blood sugar, which is a really abnormal blood sugar, dirty, or we don't say that their strep test that's positive is a dirty strep test. And so a lot of times we'll hear the thing about urine testing my urine was dirty because it was positive for a specific substance. Another term, again, that we're trying to sort of get out of that lexicon. And so there's a lot of things out there from the American Medical Association, American Society of Addiction Medicine, the American Academy of Pediatrics about terms to kind of stay away from, but also terms to think about when we're talking about patients that have substance use disorders. If there's one thing that we can do as a group to change the stigma, that's changing how we talk about patients with substance use disorders. When we look at patients that have substance use disorders, just like any chronic disease, there's degrees of severity. And so when we're thinking about alcohol use disorder or other substance use disorders, 65% of folks with alcohol, so this is surrounding alcohol, 65% of folks have either they're abstinent or low risk. This is in the United States. When we do kind of surveys of them, we have another, I went the wrong way. We have another 25% who have maybe problem or risky use. We define risky use of alcohol as 5 or more drinks per occasion for a guy, 4 or more for a girl, or 14 or more for a guy in a week, 7 or more for a girl. And so when people are drinking more than that, we know that they are at risk for diseases related to their alcohol use, such as cancer or liver disease or mental changes as a result of their alcohol use. And then we have this, which I keep pushing the wrong button, sorry about that. We have this final 10%, that sit with this moderate to severe substance use disorder, and probably that last 2.5% with severe substance use disorders. And just like patients that have severe diabetes or severe cardiopulmonary disease processes like COPD or emphysema or heart disease, or patients that have really severe cancers, there's a certain percentage of those folks that are going to die from their disease. And that's true of substance use disorders as well. It's a difficult thing to think about from this perspective, and one of the reasons why we need to work on treatment and prevention to keep people from getting to that spot. This is what I want to talk a little bit about our training of medical students and residents. When I was in medical school and residency, I remember a 1-hour video about a physician who had substance use disorder, but that's all we learned about. We learned a lot about like alcoholic cirrhosis. We learned about infections related to drug use and IV drug use, but we didn't learn about substance use disorders, how to ask the questions, how to provide support or treatment for folks. Our training right now is really focused on that intensive care. So our residents, our medical students, they spend a lot of time in the hospital caring for patients that are inpatient or in the intensive care unit or in the emergency room. And just like any disease process, the more severe it is, the more likely you are to be in the hospital. So they end up caring for patients that have severe alcohol use disorder that are admitted repeatedly because once they leave the hospital, after they get treated for their intoxication withdrawal, they end up going back to drink again. And again, we're going to talk a little bit about why that is. And so when, as a resident, that's what you're seeing for treatment of substance use disorder, the vast majority of the time are these most severe patients. And you're not getting to see that, for one of the patients who have the severe substance use disorder, that there's 100 patients with moderate to less that get well. And our students and residents need to get exposed to that and see more of the folks getting better. And as a result of that, that's the reason why a lot of physicians, when they get into practice, have those attitudes that we talked about earlier. This is one of the areas of our research. One of the things that we're really trying to focus on now is how do we best do this for our primary care physicians and our physicians heading out into practice. We know that substance use disorder starts early. This is a study or a survey from 2021 that looked at of the folks that had a substance use disorders, what percentage started before 18 or 21 years of age. And so for cigarettes, you can see that 74% of them started before they were 21 years of age. For alcohol, 73% of them started before they were 21, and marijuana or cannabis, it was 60%. And if we would go down to like 18 or 15, these numbers wouldn't change a whole lot, because the lower you get in age with initiation of a substance use disorder, the more likely you are to develop a substance use disorder. And we know that early use is difficult. Injury is the leading cause of death for children. And I keep saying I need to change this slide, or no, we have changed. I did slide, because it used to say motor vehicle accidents, number one. It is now firearm injuries, number one reason for death in that age. But alcohol increases the risk of those things, increases the risk of infectious diseases in pregnancy, as well as violence. And folks that use e-cigarettes, kids who use e-cigarettes, are much more likely to move on to combustible tobacco. One of my trick questions for our students is, what is the substance use disorder that kills the most people in the United States? And so oftentimes they'll say opioids, because there's so much stuff surrounding that, and fentanyl in our stuff. But truly is tobacco and nicotine. 500,000 people, 480,000 people a year die from tobacco-related diseases. And while our overdose deaths are significant, 110,000 per year, which is astronomical compared to what it was like prior to the pandemic, that number is a fourth of what it is for tobacco-related diseases. 9 out of 10 people who have a substance use disorder started before they were 18 years of age. And we're going to talk a little bit about why that is. So this is part of the neurological components that I wanted to address. And so at birth, when we're born, and I have a granddaughter right now who's about 6 weeks old, and she's amazing. But when we're born, we have the least cells we're ever going to have in our lives, in our brains. It doesn't take a ton of cells to look cute, eat and poop and sleep. But over the next 6 or 7, 8 years, the number of cells in our brain increases rapidly. So by the time we're 6 to 8, 9 years of age, we have the most cells we're ever going to have in our lives. And at that time, then a process starts to get rid of that, because that's noise. There's so much up there. There's so much going on that it's difficult to process stuff. And so at that point, our body starts getting rid of brain cells that aren't doing anything or just creating noise. And it starts myelinating, which means putting a cover over it that makes it work faster and more efficiently for the ones that are being used. And so it really is dependent upon kind of what's happening in a child's life as to which ones are pruned and which cells are myelinated. And brain development is interesting in kids. We hear a lot about this. Brain doesn't mature until 26 years of age. And the part is that prefrontal cortex. It's the part kind of right up in this area here that's associated with judgment, with good or bad, right and wrong, short-term consequences over long-term gain, those type of things. The striatum is the gas pedal. That's the place where, what you're doing is salient, what you're doing feels good, keep doing that. And for kids, the gas pedal is like to the floor. It's Ferrari stuff, it's like down to the floor. But their brakes aren't working very well yet. And so you can see over time that the part that is associated with feeling good is developing really, really quickly. And the prefrontal cortex is a little bit slower. when we look at this thing called adverse childhood events, and many of you have heard of these already, those 10 things that happen to kids under 18 years of age. And there's 5 of them that are directly related to the kid, and 5 of them that involve their caregivers. And I think a lot of us know what those are. What we know about that is if you have 3 or more of those, is that you're much more likely to have diabetes. You're much more likely to have stroke. You're much more likely to have cancer and heart disease. But you're also much more likely to have depression and alcohol use disorder and substance use disorders and have those difficulties, because when those adverse events are happening during that pruning and myelination process, the ones that are associated with fight or flight, the ones that are associated with violence, the ones that are associated with aggression are the ones that are salient. It's protection, right? The kids are doing the things that they need to do to stay alive. Those behaviors, those things that happen end up leading to these difficult disease processes as we get older. This is not any slide that you need to memorize. I just threw it on here because epigenetics is a gigantic part of this. And so this is that process where there's not genes changed, but genes that are turned on and off, depending upon things that are happening in our lives. And the whole thing surrounding substance use disorders, especially when we're starting as kids, involves our epigenetics. Now, epigenetics has a really positive thing. We know that early reading has an impact on education in kids. If kids are reading, getting read to with grandmother or a mom or dad or grandfather, whatever, they're having good feelings because they're with that person who loves them. They're seeing the page turn right to left, or left to right, I guess, depending, or up and down, depending on where you are. And you're learning the processes of reading, and it's an enjoyable process. And we know that kids that get read to early are more likely to do better in school because of that process. So there's positive things as well. But there's also the negative aspects of that. So when a brain is exposed to substances early on, the epigenetic processes lead to the pruning of cells that maybe are focused on reading and those things, and really gets rid and myelinates the ones that are focused with the rewards associated with substance use disorders. This is sort of my way of explaining substance use disorders to patients. And so this is what I would like to do, thinking about the neurobiological concepts, is to explain it with these 3 stages of substance use disorders. And maybe some of you have heard these before. This model was put forward by the director of the National Institute of Alcoholism and Alcohol Abuse, George Koob, and Lamola's partner, and then also the director of NIDA, National Institute of Drug Abuse. Her name is Neurological. They're the ones that kind of came up with this heuristic model of understanding substance use disorders. And this thing works for me. It helps me explain this to folks. But we also know exactly in the brain where all these processes are happening, which is also an important part of this. So the first thing I want to talk about is the binge intoxication. There are maybe some folks on today who have never used a substance, never had a cigarette, never used any alcohol, and so maybe don't understand this, but a lot of us have. And so we understand the good feeling associated with having a drink, or the good feeling associated with maybe using some nicotine. And that's that reward process. Dopamine is the neurotransmitter involved with this. And it's an important kind of part of all this. We often think about dopamine as the thing that causes pleasure in our bodies. It's the thing that makes us feel good. And to a certain degree, that's true, but it really is the neurotransmitter of wanting something, not the neurotransmitter of liking something. And there's a difference. So when Homer Simpson sees a donut, or Ken Zoucha sees a piece of carrot cake, or I see my granddaughter, I'm getting a spike of dopamine. Dopamine is released when we are doing something that's going to keep us alive as a species. So this process exists in every single mammal. So eating, of course, is one of those. If you eat, you're more likely to survive. So you get some dopamine with that. Sex causes increase in dopamine because if we make more of ourselves, we're more likely to stay alive. Being in groups of people, for some people, we have some extreme introverts where that's so caustic and so difficult that they aren't able to do that. But most people like having people around them, and because it causes some release of dopamine. Oftentimes, I think about the sort of like Darwinian sort of things that happened that kind of made this process kind of kick into place. So I'm thinking about, that caveman kind of walking through the jungle, with his spear, and the saber-toothed tiger shows up and he yanks his spear at the tiger and it kind of bounces off and the guy is lunch. But if Caveman Joe is walking around with 20 of his best friends with their spears, they're having saber-tooth tiger for supper. And so it's just kind of that whole thing about, these are the things that we do to keep us alive. It causes dopamine to go up. This is my little kind of thing about what a cell. So this is two cells kind of connecting to each other. There's a little space in between them. Proteins, dopamine in this case, are released. They attach. They cause a little bit of release and stimulate the next cell. And then they get taken back up into this cell when they're done doing their thing. So that's kind of where it's at. It came out of survival, and it's the neurotransmitter of wanting. Now, what happens with substance use is that we are using a substance kind of on a continuous basis that's causing these gigantic releases of dopamine that are way above what's supposed to happen, way above what's supposed to happen. And our body loves balance. We do a ton of things to maintain balance. We get hot and we sweat. We get cold and we shiver. We're thirsty and we drink water. We're hungry, we eat food. So we've got those things, and there's I would guess hundreds of thousands of those processes inside of our body. So it works to maintain balance. Now, when dopamine's in there just constantly because of substance use, the body adapts to that and says, whoa, way too much dopamine. We can't do that. And so what happens over a prolonged time is it decreases the amount of dopamine available to be released, and it decreases the number of dopamine receptors. And we're going to talk about what that means here in just a little bit. So over time then, as there's less dopamine and less receptors, it takes more and more and more and more substance to get the same effect. And this is tolerance, right? This is just total tolerance. We're going to talk about what it means to stop when your dopamine has gone away. So that's kind of our dopamine kind of piece of things. The next is kind of that negative affect and withdrawal. So that's the number 2 part. So that's the thing that happens when we stop using a substance after we've been using that for a while. I wanted to show just one quick sort of, this is a functional magnetic resonance imaging study. And what I wanted to show is that, we're not just like trying to guess these things. I wanted to show you that we have information that tells us that what we're talking about today is true. So this is a functional MRI study in a control, somebody who doesn't have a substance use disorder. And these darker parts kind of in this area, this is that system we're talking about. That's showing dopamine activity. That's what that's showing. Here we have somebody who has substance use disorder and using substances. And you can see with cocaine, there's just no red at all. Alcohol maybe a little bit, but it just disappears. I just wanted to show this real quickly, just to show you that we're not just kind of pulling this stuff out of the air. We've got a bunch of stuff kind of looking at this to tell us that this is true. One of the things that happens when we're attacked, or we're in danger, or we have an infection, or we have something that we get injured, we get scared by something, is we have a system inside of our bodies that increases our fight or flight response, gives us energy, makes us feel uncomfortable, so we get out of that system. And that's this stress axis system that involves this thing called CRF, or corticotropin releasing factor. So normally, when we're kind of hanging out through the day, unless you have severe anxiety disorder, which in case this is high all the time, but you're hanging out through the day, and all of a sudden the velociraptor shows up, bad velociraptor, that's a bad thing. And so he shows up and this thing takes off, and you're like, I'm scared. It increases your muscles strength, increases your ability to run. It tells you, get the heck out of there, all that stuff, because you feel really uncomfortable because of the release of all that system. So that's what happens when the velociraptor shows up. Or, let's just say, I don't know, you're almost in a car accident, or, whatever. So this kind of deal is there to kind of kick things out for you and let you get away. So this is Cocaine Bear. And I guess that's a movie now. So who knows? Wow, just weird. So when somebody's using, so I just wanted to use this to show you that when somebody is using substances all the time, it is that our body sees that as an attack. It's something that's happening that's not supposed to be happening. And it tells us, this is bad. What you're doing is bad. So this system is constantly ramped up when people are using substances. And so you've got this high kind of corticotropin release, CRF, all the time. And when you've got substances sitting in your body to calm all that down, to take away some of that stuff with some euphoria or numbing up the sensations or the feelings of the mood or whatever, we don't really notice this very much. However, when all of a sudden you take the substances away, let's talk first about what happens when you get in danger. So your system is high all the time because you're using substances. So the bear shows up, or the velociraptor shows up, or the threat of prison comes around. There's no threat because you're already at high threat level because of the substance use. And so these things just don't mean much to people. They don't create a sense of unease or a sense of fight or flight or a sense of whatever. So you wonder why people continue to use substances, why somebody with a driving under the influence continues to drink after that, or why somebody who has substances in their possession that are illegal and would get arrested and possibly jailed, why they keep doing that. This is one of the reasons, is that it's just not a threat because of how our bodies have adapted during that negative withdrawal. So when you think about, first of all, the dopamine, we talked about the dopamine levels get lower and lower and lower. And dopamine, that neurotransmitter, also motivates us. It causes us to get out of bed in the morning. I said it does. It's not the neurotransmitter of euphoria, but there is some good feelings associated with it, some energy associated with it, some positive kind of impact about your environment and what you need to do. So all that stuff is because of dopamine. So here's somebody who's been using substances for a period of time. Let's say alcohol or opioids, and they've been using for several years, and their dopamine levels have been dropping. Their corticotropin releasing factors been getting higher and higher and higher all the time. This is where they're at when we're asking them to stop. There's another neurotransmitter called dynorphin that creates dysphoria, creates a sense of unease and irritability. So this is where people are at when we're asking them to stop using a substance. And so when they stop, they have no dopamine. So there's nothing left to create a sense that, I'm using a substance, my kids don't mean much to me anymore. The pleasure I have from that doesn't click. The motivation of a job kind of goes away. The motivation of being around friends and family is just gone because there's no dopamine when my substance is gone. And also, when you take it away, there's this high level of CRF and cortisol, creating this sense of dysphoria. And so when somebody stops using substances, and this is truly what it feels like to stop using opioids, when somebody stops using substances over time or has been using, and then all of a sudden we ask them to stop, this is what they feel like. This is what Willa was feeling like when she was in treatment for her opioid use disorder. And this is what Mary was like when she was trying to stop using her alcohol. Now, this is the worst in the first kind of, 2, 5, 6, 7 days or so. That's when this is the worst. There's the physical symptoms, but there's this thing called protracted abstinence syndrome. A lot of us know it as PAWS, post-acute withdrawal syndrome. And so, these eventually will start leveling out. Dopamine will go back up, CRF will go back down, and we're talking about just 2 neurotransmitters. There's so many neurotransmitters involved with substance use, and they all are affected in somewhat the same way. So they eventually go back, but it takes a while. The things that are caused after you get through that acute kind of physical stuff are these symptoms. And so this is what people feel like in the first 2 months, 6 months, a year, 18 months after they stop using substances, depending on what they've been using, how many substances they've been using, and for how long. And it's not like people feel like this all the time, but this is what they feel like a lot of the time. And it just slowly gets better over time. The symptoms get better and better over time, but they don't have dopamine, and their CRF is sky high, and serotonin is really low, and adrenaline is really high. I mean, all those things create this difficulty sleeping, high level of anxiety. The anhedonia is probably kind of the worst symptom that I experienced. And anhedonia is, the only way I can describe it is everything sucks all the time. The technical word, look that up. It's all our medical literature now. Everything sucks all the time. And it's just gray, and there's no motivation to do anything. The things that used to create joy and that you would get excited about no longer do that. You can't focus, irritable, yelling at everybody, angry all the time. And these things you're having while you're trying to work and while you're trying to go to school and while you're trying to be a member of your family. You feel this way. You're trying to look normal, trying to feel okay, but this is the way things are. And so this is why we consider this sort of a substance of no choice. If we don't help people with this part right here, if we don't see this truly as suffering, that is more than just willpower, just suck it up. It's just a couple days, just suck it up. Or, if you feel that crappy, don't use again. That's not what happens here. If we don't work on people, help them in this spot right here, it's a substance of no choice. Their bodies, their brains will trick them and get them back into using their substance again to make the suffering go away. So the last thing I want to talk about was anticipation, preoccupation. So that's the prefrontal cortex. That's that last part that goes away. Let me just look here. So I know we just have like 15 minutes left. We'll kind of keep working on things here. So this is the part, again, that's associated with judgment. So normally when our prefrontal cortex is working, we're able to make decisions about short-term pain that will lead to long-term gain, or short-term gain that will lead to long-term pain. So when everything's working okay, we've got that little thing in there that says, maybe I could grab that piece of chocolate. Maybe I could pull the fire alarm and get away with it. Maybe I could speed down I-80 and not get caught. And so we've got that little thing back there all the time that's like pushing on that gas pedal, but our control is better. And so it says, no, you shouldn't speed. Don't pull the fire alarm, dummy. That's not going to get you in. You're going to get in trouble and get fired. All that stuff kind of goes through your brains. I don't think about pulling the fire alarm. I really don't. But it's just one of the things I think about with just like, okay. So that's the way the system is normally. Now, when you start having dysfunction of your prefrontal cortex, so this is based on people that have had an injury from an accident, a tumor, infection, a stroke, those type of things. The further back the lesion is, the further back the insult is to the part of the brain, the more people move over to this side right in through here, where you no longer have control. And the automatic is there. The gas pedal's down to the floor. This is what it's like in adolescence, actually, where this automatic gas pedal is there and the control isn't really good. And so it's just go, go, go. Don't think about the consequences. Don't think about the outcomes. Don't think about what kind of trouble you're going to get in. Just go. And so that's what happens. Now, we use this thing called the Iowa gambling task. I need a drink here. The Iowa gambling task. And so this is a task that looks at prefrontal cortex function. So it has 4 decks in it. So the 2 of the decks, it's not like a poker game or pitch or cribbage or anything, but 2 of the decks have cards that when you turn them over, it's a win. There's a lot of them. The wins are pretty small. There's some where it's a loss. So, it takes stuff away from you, but they're pretty rare. So that's 2 of the decks. The other 2 decks are considered the quote unquote bad decks. This is pulling the arm. I guess you don't pull arms on slot machines anymore. You push buttons, but this is that deal. So there's some wins. They're huge, but they're very infrequent or rare. And then there's losses that are pretty large and pretty frequent. So those are the 2 decks. Now, when your prefrontal cortex is working and you're doing this thing, you will start picking from the good decks. If you have a gambling disorder, if you have a substance use disorder, it doesn't work that way. But if it's working, you will start picking from the good decks just automatically without even thinking about it, because the wins will kind of start coming through. So this is what happens when people's prefrontal cortex isn't working, is they start picking from the bad decks. They can't pick from the good decks because they don't have that short-term pain, long-term gain kind of thing happening inside of there. When we have people that they're, this area right in through here, it's working well. This is kind of what that looks like. When it's not working well, somebody that has cocaine use disorder, oh shoot, my use did stay there. So then they're in this spot right through here. So let me see, I'm going the wrong way. So when that prefrontal cortex is kind of sitting in and not working the way it's supposed to, and this is what you're feeling like, either in that early recovery or in the late recovery, you can be at that spot where you've got the protracted absence syndrome, and that's what you have, and it's going to get better, and just stick with it. And if you use, it's going to get worse. If your prefrontal cortex isn't working because of the changes that happen with substance use disorders, you are much less likely to be able to do this. Again, one more part of that substance of no choice is that's kind of what's happening. So there's definite brain changes then that happen as a result of substance use that lead to folks not just being selfish and foolish and irresponsible, but having a disease process where they are suffering when they aren't using their substance. They're no longer using to get high anymore. There's no euphoria in this at all. All it is trying to feel okay, getting out of pain and suffering. And again, if we don't help people with that pain and suffering, it's going to be really tough for them to find recovery. There's three things that are huge kind of triggers for people in early recovery. One is stress, and any kind of stress will do that. The second is triggers. We hear about this a lot. Triggers. What's your triggers? What's your triggers? What's your triggers? And we think a lot of times, I do it, we think about a guy who's or a girl trying to stop drinking, and they walk into a bar with alcohol. And all of a sudden their brains are starting to think about how good that first beer felt, or that first drink felt, decades ago or whatever. That's all our brains can kind of think about. It can be smells. For a while I worked at a treatment center in Hastings, and that was in a pretty wooded area where we had lots of wild animals, including skunks. And so when the skunks were doing their thing, our kids would start having cravings. They'd start kind of say, man, I really want to smoke. I really want to use cannabis. I really want to use marijuana. And that smell part was because of that. And then there could be music. There can be sounds. There can be a lot of different things that kind of do that. For people that have like a substance use disorder involving pills, sometimes it's a pill bottle. Just holding or seeing a pill bottle is a trigger. And what happens is our body actually starts releasing dopamine even before we start using the substance because of that. So this Nora Volkow, Dr. Volkow that I talked about, who's the director of the National Institute of Drug Abuse, she did some studies looking at this. And what she did was that she looked at people who had cocaine use disorder. And there were, I can't remember the numbers, I think 20, but I can't remember. So what she did was she took them and she put them into the scanner. And then she showed them, they hadn't used cocaine. They showed them pictures of cocaine and pictures of like their dealer and pictures of those things, measured the amount of dopamine release in that area, and then took them out and then put them back in and had them use cocaine. And what she found out was that the cocaine lit up, or the thought or the pictures or whatever lit that area up more than the actual cocaine use did. And so that's the power of those triggers. Why we tell people you've got to change your playmates and your sandboxes. You can't be in those spots anymore because those triggers are so powerful. They start before they start. So they're below the level of consciousness, below the level of kind of what's there. And so we talk a lot with people about just trying to keep yourself safe. The final thing is, if you get a substance in your body that may not be your substance that was what you were addicted to. So, somebody who has an opioid use disorder, drinking alcohol can be really dangerous because it can start this process up, especially if you've got a bunch of stress and you're sitting by the people you used to use opioids with. Somebody with alcohol use disorder who gets opioids, that can be a gigantic trigger and create that sensation of craving and desire to use a substance that's below that level. So again, we're at these, long-term results of neuroadaptations that happen over time, and it gets better. This is the fMRI stuff again, showing kind of a healthy person, somebody with methamphetamine use disorder, and what things look like after 14 months. So stuff definitely gets better. It definitely improves. The big thing is who becomes or who acts as the prefrontal cortex when it's not working. How do we help people find recovery and make these decisions when that's not, and you're picking from the bad decks all the time, and you see that piece of candy sitting right inside that mouse trap, and or the bar right there, or I have a lot of people who stop in gas stations and pick up shooters on their way home. You're driving by that gas station and it triggers things, and your car automatically pulls into the parking lot to grab a couple of those. It's a deal. And so that's why we talk about having people support folks around people. That support system ends up becoming the prefrontal cortex. Judicial system for the kids that I see becomes the prefrontal cortex. They have the ability to strongly encourage kids to do their treatment and to take their medications, because everything is telling you and people around them that that's what they should do, but they're like, no way, I'm not doing it. And you can have a prefrontal cortex, a judge acting as that prefrontal cortex. There's a lot of strategies that we use to try to improve some of our attitudes and an understanding around substance use disorders. And so one of the reasons I talk about myself being in recovery is that when you see people in recovery longer term, that's a positive thing. It encourages and reduces stigma. When we see patients that are using medications to get better, that improves stigma. When we kind of think about it, and we have mentorship, and with our medical students, our mentorship surrounding this, or they get to rotate in situations where we're treating patients with substance use disorders. Lot of reflection exercises. So there's some good news. Things are getting better. This is from this is from a survey called Monitoring the Future, looking at the changes that we're seeing in substance use with kids over time. And we definitely saw some drops in 12th grade, in 10th grade, and in 8th grade with past year of illicit substances, seeing some drops in alcohol use over time as well. Prevention ends up being kind of one of the things we have to think about a lot, because it is definitely easier to not start than it is to stop after you've started. And so we've got some evidence-based kind of prevention things. A Talk They Hear You campaign, encouraging families and teachers to talk with kids about substance use. And then, we're working really hard to train our residents and our medical students on evidence-based care of substance use disorders. There is some evidence, and this is a couple of years ago, looking at family medicine visits into their office, suggesting that 30 to 35% of their visits had something to do with a use disorder, whether that be an overeating disorder or a gambling disorder or a substance use disorder or nicotine, that they had something they were coming in for. And it may be a sequelae or a consequence of that: stomach aches because of alcohol use disorder, headaches, or difficulty breathing because of nicotine use disorder, whatever happens to be. But we need to do a better job of training our students and our residents. And that's really what we're focusing on right now at the Med Center. There's a lot, don't get me wrong, there's a ton happening here. But one of the things that our division is working on is how do we get better at training our medical students and our residents. And we have some ongoing things that we're changing and looking at right now as far as some studies surrounding that, to look at that. This is just a couple of things that I wanted to show you surrounding just some of the literature that's out there. There's some stigma among health professionals that we have our residents and students read, looking at this and talking about this. We have some folks here who are doing some research and studies looking at how training surrounding substance use disorder can improve care. This is from our GI fellowship for hepatology, looking at our alcoholic hepatitis program, and looking at how maybe folks that are GI specialists with hepatology might have advantages to rotating with addiction medicine as a result of that. Treatment's out there, and it exists, and while we have a lot, we don't have enough, and things there needs to be improvements surrounding that. And I really liked SAMHSA's message of this: behavioral health is essential to mental health, and prevention works, and treatment's effective, and people can recover. And we see it every day out there. So that's kind of the end of my message today. I'm open to any questions or comments or anything that anybody would like to ask about or talk about today. So thank you very much for letting me participate today.
Thank you so much. And if anyone who is listening live has any questions, I'll give you a moment to see if anyone pops anything into the Q&A. I know I really appreciate just how you're able to communicate some of these concepts. I love the pictures of the brain from, maybe an average one to one who is struggling with a substance. Appreciated the tips on stigma and how by changing our language, we can have an impact on how other people perceive addiction. And the threat level, like the thinking about how they're living in a place of high threat. So that some of those consequences, or that
Yes.
many people might think would be effective, why those don't resonate with them.
Right.
Is very enlightening.
Thank you.
Yeah. I appreciate you being willing to share some of your personal
Sure.
story and some of your humor and love for your new granddaughter.
Yeah, for sure. For sure. Yeah, no, I appreciate that for letting me share that a little bit. Yeah.
Well, I'm not seeing any questions, so I will go ahead and wrap up. Thank you for joining us today. And for those of you who did sign up for continuing credit, I'll be following up with you on that shortly. Thank you and have a good day.
Thanks a lot. Thanks for having me. Have a good day, everybody.
Yeah, thank you.
Bye.